Okay, perfect. All right, hello everyone. Welcome to your MedSurg II tutoring today. Before we start, please go ahead and scan the QR code, sign in. As always, I really appreciate it. I hope you guys are all doing well. I know it is toward the end of the semester. Just hang in there. We will get through this. So today we will be covering the oncology nursing care for cancer patients, a very interesting topic, and it also a last topic of your MedSurg II, the last content that you guys need to be covered before your third exam and as well as the HESI. So without further ado, we're gonna go ahead and get started. Let me fix it into a single page. Okay. All right. So MedSurg II tutoring oncology. So what do we have to focus on? This slide is the summary of what we have to focus on for the topic of oncology. We need to know the disease process and the risk factor of each disease. Including breast, lung, and colon cancer. That would be the three biggest body system that we need to know regarding cancer for this topic. We need to know about the screening. There will be question that she will ask in the exam. When do we start screening for certain patients who are at higher risk, for example, colon cancer or breast cancers? How do we manage cancer specific side effects? So a lot of patients who have cancer will be going through chemotherapy or radiation, and there will be side effects regarding that, like for example, alopecia. So what kind of nursing thing that we have to do in order to manage those side effects? We have to know the sign and symptom of cancer, which we'll be covering later in a later slides, and that will be very important. There will be question about sign and symptom of cancer on the exam 100%. Which group are more prone to different cancers? So we have to know this as well. And then which area certain cancer are likely to spread. For example, lung cancer typically spreads to the bone. Prevention is key in cancer, so always have a healthy diet, low in cholesterol, fat. Make sure you wear sunscreen when you are out in the sun, and avoid tanning bed, as well as eating unhealthy food for a long period of time. And what will you teach a patient? Something like that. So let's go ahead and get started. So what is cancer? So basically cancer is uncontrolled and unregulated cell growth. So normally the cells in our body, they grow and die. They grow in a fixed period of time, and they have a regulation when they grow. However, in cancer, the cell can grow so rapidly, or it doesn't reach the maturation of the cell, and it causes an abnormal growth in the body. This can be abnormal replication, how fast the cells are dividing. Apoptosis is programmed cell death, which means like the cell basically burst on its own. It kills itself. It's suicide. Example: red dress at a black and white party. So that means is the red dress would be the cancer cells, the red cancer cells, and it comes to the party where there are other cells, and they start making other cells, copying them, and the mutation, the cancer is spreading. So that what that means. It can affect any tissues of the body: skin, bone, lungs, breast, colon. Sometimes it can be painless, and it can be a fixed tumor. So again, the faster the replication of the disease cells, the harder to treat. it's pretty self-explanatory. If the cancer cell is spreading too fast, it will spread to the bone or spread into other area of the body. Therefore, it will be harder to treat. Apoptosis is evading natural cell death. Okay, and next we have risk factor. What are the risk factors for cancer? Family history, genetically, especially breast cancer. So for example, there will be patients who have family history of breast cancer. So for the mother have the breast cancer or the grandma had the breast cancer. So when the daughter, we can prevent it if we uh, stop her from taking contraceptives or having early breast cancer, having early breast scan or removal of the breast tissue before the cancer cells can occur. So breast is usually is family history. Then tobacco use. Tobacco is a carcinogenic agent, so it is a substance that could lead to cancer. Then environment, if we live in a chemical heavy city or often live in a polluted area. Obesity, usually the result of cancer from obesity is because of the unhealthy diet, alcohol intake, older age, immune function, food additives, nitrate. So the biggest risk factor for cancer is family history. Usually Caucasian, lung, breast, collateral, and prostate cancer. In African American, lung, prostate, breast, collateral, and uterine. Asian, breast, collateral, prostate, lung, and stomach. Hispanic, prostate, breast, collateral, and lung. You guys don't really need to know those. Just know like this generalized risk factor. Key preventions. So what is the key preventions? Obviously, we stop smoking or avoid exposure yourself to someone who smoke, because secondary smoking is worst. If they smoke, they inhale one out of 10 of the bad smoke into their lungs. But the secondary smoke, when we inhale the air, when they exhale after smoking, those air are worse, and we receive like the 90% of the carcinogen from the person who smokes. So secondary smoking is worse, and so avoid yourself or just leave whenever someone smoke. Avoid sun. The sun is good, but make sure you guys have your sunscreen to prevent skin cancer. Balanced diet. We need to avoid excessive intake of animal fat, lunch meats, those Lunchables, sausage, bacons, high in cholesterol, high in LDL, unhealthy, unsaturated saturated fat. Decrease red meat, limit alcohol to 1 to 2 drinks a day. We need to increase intake of bran, broccoli, cauliflower, Brussels sprout, cabbage, food that higher in vitamin A and C, the pretty colors of our veggies. So yeah, just eat a lot of fibers. Fibers are amazing, good for digestive system, good for your health. So a lot of fibers. Behavioral therapy, we changed the perception of the stressor. Stress is a good thing in life, but if we are consumed by stress, it can cause inflammation in the body and may lead to other issues, including cancers. We have to learn how to cope with stress, enjoy consistent period relaxation and lasers, practice self-examination. This is a very important piece. Please remember that practice self-examination is one of the key prevention of cancer. For example, in male, we do testicular examination, and in female, we do breast examination. But to be honest, even male can have breast cancer as well. So just check your body every monthly, the same day every month, to make sure that there's no abnormal lumps or abnormalities that you guys found in your body. And then get adequate rest and exercise. So pretty self-explanatory. All right, so this slide is a really important slide. This will be on the exam, like I said earlier. This is 7 warning signs of the cancer. We have to know this by heart. We have to know what are the warning signs of the cancers, okay? So they have the abbreviation of cautions. So C stand for changes in bowel and bladder. Like you guys, we suddenly experience difference in bowel, can be excessive diarrhea, or suddenly severely constipated, or bladder, we pee so much more, or we don't pee at all. A sore that won't heal, like we have an injury, a wound in the mouth or on the skin that just will not heal and just keep bleeding, or it's just not healed. Unusual bleeding or discharge, especially from the genitalia, or it's just from a sore on the body. There's unusual bleeding or discharge. Thickening of a lump, usually if it thicken above the clavicle, that is usually a very dangerous sign. Around the neck, and usually in female, it will be around the armpit, which is indication of breast cancer. So thickening of a lump may indicate is one of the warning signs of the cancer. But sometimes as human, we always sometimes experience thickening of a lump because of the inflammation that going on in the body, or there's like the body trying to fight off a bacteria. So sometimes we have a lump too. Having a lump does not necessarily mean that we are having cancer, but it is one of the warning signs of the cancer. Indigestions, obvious changes in a mole or a nodule. So you guys heard about like this mole on the skin, and we go check, and then sometimes it can be a cancer mole due to excessive exposure to the sun. So if there's a mole that is like not rounded, or the border is just like not approximated, it's just all over the place, usually those are the warning signs of the cancer. Then nagging cough or hoarseness, like the voice changes. There are, self-explanatory. It's just different changes in voice, or excessive cough, usually indicator of lung cancer. Just warning signs. All right, next we have colon cancers. So this is one of the system that we need to focus on. Remember, colon, breast, and lung. So first, risk factor for colon cancers are polyps, inflammatory bowel disease, and chronic constipation. Genetics, smoking, drinking, high fatty diet, and being a male. Sign and symptom of colon cancer, including rectal bleeding, anemia, changes in bowels, habit, and stool. Usually the patient get hyperdrive in their digestive system, where they having diarrhea for multiple days, or for a long period of time. Vague abdominal pain, fatigue, abdominal fullness, weight loss. Diagnostics testing for colon cancer include endoscopy, CT scan, MRI, and occult blood. Occult blood is usually like is the diagnostic where they take pieces or amount of stool from our body, and then they check if there's blood inside it. Screening, colonoscopy, and fecal occult blood test. So beginning for regular male who are healthy, who does not have family history of colon cancer, we begin at age 50, and we do it every 10 years or every 5 years if polyps are present. We then, if the patient is have a family history or at high risk for colon cancer, meaning they have inflammatory disease, or they have a chronic constipation, or they are a heavy smoker, we begin screening for them at 45. Okay, so these number can be important because it's maybe asked for the exam. Side effects include diarrhea, leads to fluid volume deficit or electrolyte imbalance. So remember, when we vomit, we lose acid, so it causes metabolic alkalosis. However, when we have excessive diarrhea, it will lead to metabolic acidosis. Okay, so that's the difference. So the electrolyte imbalance for diarrhea is metabolic acidosis. And constipation, sores in the mouth, stomatitis, and this can lead to weight loss, because when we have sore in the mouth, the appetite of the patient usually decrease. Fluid and electrolyte imbalance, like I said, because they have excessive diarrhea, they can have loss of potassium, they can loss of a lot of sodium, essential electrolyte for the body. High risk for infections. All right, next we have breast cancer. So risk factor for breast cancer is hormonal receptors. Factors that drive breast cancer cells include estrogen and progesterone. Herceptin receptors, cancer eats and grow faster. So the risk factor are genetic, high dose of radiation before 20. What it means is, like, before 20 years old, the patient have a lot of issues where they need and require a lot of X-ray or radiation. This can predispose them to having breast cancer. Menses onset prior to 12. It means that they usually, there's a term called precopious puberty, where the child, the pediatric patient, experience puberty in an early age, and especially in a young female who experience menstrual cycle before the age of 12, they are at high risk to develop breast cancer in later life. So for children who have menses or menstrual cycle before the age of 12, we have to scan them and screen them early. Or having no children. So usually women who have no children will often at higher risk than women who have children in developing breast cancer. Sign and symptom include change in skin appearance, discharge, or lump in the breast. All right, so the breast, sometimes it discharge weird substances. That can be a warning sign of the of cancer. And of course, lumps on breast. Diagnostic testing of breast cancer, including mammograms, needle aspiration, tissues, pathologies, screening, and early detections is key. Surgery consideration include post-op care is critical. Bleeding, no elevation of arm, restrict extremity for life, management of lymphedema. So what is post-op care? Because usually patients with breast cancer or who want to prevent breast cancer, they will have a mastectomy where they remove one side of their breast or both breast. So usually post-op care for this patient, we need to make sure that we do bleeding precaution and also tell them not to elevate their arm during the healing time, and definitely restricted the extremity for life if they have like one-sided breast. And we don't restrict it, meaning no blood pressure cuff, no IV, no nothing on that side of the arm. Next, we have lung cancer. So risk factor for lung cancer is obviously smoking. They inhale carcinogen containing air into the lungs. these gases or chemical or gases from chemical environmental from like the refinery or a busy street, an urban area where they are highly polluted, can lead to lung cancer. Sign symptoms include persistent or nagging cough, hoarseness, hemoptysis is coughing up blood, change in endurance, they're not able to perform the activity that they used to, chest pain, pleuritic pain on inspiration. It's like the pain over chest when they inhale. Diagnostic testing are X-ray, usually look like a solid mat, biopsy via bronchoscopy, sputum collection, CT, MRI. All right, so early detection is key in all kinds of cancers, especially in breast cancer. So in women, they definitely need to do a lot of self-exam, regular self-exam, also do clinical exam, including mammograms, pelvic exam, and pap smear. So breath exam. So if doing self, it should be done monthly, 7 to 10 days after the menstrual period, in the shower and laying down. If they have menopause, do it on the same day of the month, like a birthday. Why? Because when they start menarche, they are tender and in pain. Position client in a semi-flower position, turn from back to an affected side with the affected arm elevated above the level of the heart. That's how usually in the doctors, they do examination, I guess. Mammograms, we have to teach patient or provide washcloth to wipe off. Teach them no deodorant, no lotion or powder. All of these things look like calcium buildup and appear cancerous even though they aren't. So make sure to know that the teaching before the patient does the mammograms. Definitely no deodorant, no lotion, and no powders. If they have it on, we have to give them the washcloths to wipe it off. High-risk patients start at age 30. So remember who are high-risk patients. Those high-risk patients are the one that have no children, have menopause before 12 years old, or have family history, mother or grandma, whoever in the family having breast cancer. So those are considered high risk. And we need to start at 30 years old. Screening begin at age 40 unless it's high-risk patient. Then pelvic exam yearly beginning at 20 years old or when sexually active. Pap smear, we needed to do it every 3 years, although people typically get it yearly when pelvic exam are done. No sex or douching prior to the pelvic exam or pap smear. Don't want anything else on the exam slice. Colonoscopy and fecal occlude blood test beginning at age 50, Q10 years or 5. If polyps present, beginning at age 45 if immediate family history or high risk. So again, who are at high risk for colon cancer and require occult blood, those are men having bad and healthy diet, obesity, and having inflammatory of the bowel, inflammatory disease. Yeah. All right, next we have early detection prevention for men. Men can also have breast cancer, so they need to also do self-breath exam, self-testicular exam, prostate specimen antigen, PSA. Prostate specific antigens and digital exams. So who are the high-risk patients? So let's just take a look. So similar to women, we do self-breast exam monthly, self-testicular exam monthly, begin at age 15. Most common is from 15 to 36. So we need to teach these early on, monthly after puberty. Prostate-specific antigens and digital rectal exam. Digital rectal exam is when the doctor literally use the both hand, go up the anal of the man and feel for the prostate to feel or see if it's enlarged. That's called digital rectal exam. Yearly begin at age 50. Normal lab value is 2 to 6 for the PSA. High risk is African American men with father, brother, or son who also may have issues with the prostate. Colonoscopy begin at age 50. So this is the third time this is repeated. So it must be very important. Beginning at age 50, every 10 years or 5 years if polyps are present. If it high risk, such as immediate family history or high risk, begin at age 45. Okay. So review type of precaution. So there are 2 precautions that are very important in the oncology chapter, which is the neutropenic precaution and bleeding precaution. So for bleeding precaution, we have to do certain things to prevent patient from bleeding, falling. So we have to review that. And then neutropenic precaution. So remember, no fresh food, no fresh flowers, and make sure that there are masks and gown before entering the patient room. Patient can mostly only eat canned food or food that has been pasteurized. So no fresh vegetable for them, okay? Oh, and also no milkshake from fast food restaurant, if you guys remember, because we never know if they clean those machines or not. So that's one of the neutropenic precautions. All right, so how do we distinguish benign and malignant cancer? So this is important as well. She will ask you guys to distinguish the benign and the malignant cancer cells in the test. So in order to, what does it mean benign and malignant? Benign is, it's just abnormal growth. It does not causes spreading or metastasize to the bone or other places. And malignant is bad, like it's spreading and it's leading to other places on the body. So benign is well differentiated. It grows by expansion, not metastasizes. It gets bigger, but it doesn't move, it stays there. Malignant is undifferentiated, is spread by metastasize, move to multiple system, not good. Indifferent, not the same as the original tissues. Therefore, it will not act like normal tissues, so it grows and spread faster. Typically, your grade 3 and 4 cancer stages would typically have undifferentiated cells tissues. Differentiated meaning same, function almost similar to normal tissue, so it grows very slow and easier to treat. So usually benign tumor, they are just stay occupied, but malignant tumor or cancer cells, they not only stay occupied, but they also spread faster and move to other body system. So that's dangerous. Grade versus stage. So what does it mean is grade? Grade is the classification whether it is differentiated or undifferentiated. Stage is the size of the tumor and extent of the disease, whether it has metastasized. Classification T is primary tumor, N is absent or present and extent of lymph node metastasis, M absent or present of distant metastasis. So again, T is the extent of the primary tumor. So TX meaning primary tumor cannot be assessed. T0 meaning no evidence of primary tumor. TIS is carcinoma in situ. T1, T2, T3, T4 increase in size and or local extent of the primary tumor. And absent of the or present and extent of lymph node metastasis. NX meaning region lymph node cannot be assessed. N0 meaning no regional lymph node has been metastasis. And 1, 2, 3 increasing involvement of regional lymph nodes. M absent or present of distant metastasis. MX meaning distant metastasis cannot be accessed. M0 meaning no distant metastasis, and M is distant metastasis. Metastasis meaning like it spread to other places of the body. Okay. And carcinoma in situ is the carcinoma, the cancer agent. It stay and remain at the area where it's first originally developed. So stages of cancer include initiation, when the cells start to mutate; promotion, when the cancer cells start to proliferate. This state, cancer is still reversible. Progression is increased invasiveness and beginning to metastasize. The grading, grade 1 is mild dysplasia, low grade, well differentiated. Grade 2, moderate dysplasia, intermediate grade, moderately differentiated. Grade 3 is severely dysplasia, high grade, poorly differentiated. And grade 4 is anaplasia, undifferentiated, high grade, cell origin, hard to determine. And grade 5 is cannot be assessed. This stage of cancer is the development of cancer cells. Next, we have extent of the disease classification. So staging based on anatomic extent of the disease, meaning whether they have been metastasized or they have moved to other area of the body yet. So stage 0 is when the cancer is in situ. That's meaning it have not been moved. Stage 1 is tumor limited to tissues of origin is localized. Stage 2 is limited to local spread. For example, like it's around the armpit area, so there will be multiple lymph node, or multiple. It's get bigger in the armpit area. Stage 3 is when extensive local and regional spread. For example, originate in the armpit area, they move to the breast, to the above the clavicle, so around the area where it started. Stage 4 is metastasis, whereas it's moved to other body system or other area of the body as well. TNM classification system used to determine anatomic extent of the disease, involvement, tumor size, and invasiveness, present or absent of regional spread to the lymph node is N, metastasis to distant organ sites is M. So what are the treatments? The treatment are chemotherapy, radiation, or surgery. Goals of treatment include trying to cure, trying to control, or palliation, where we accept and providing the most comfort care for the patient instead of curing the disease and having the patient going through a lot of pain. Surgery, so prevention of spreading, eliminate risk of cancer development, prophylactic measures. So what that means is, like I mentioned earlier, some women, they have a family history of breast cancer, so they decided to have a mastectomy, where they remove their breast to prevent the spreading even before they have cancer. So it's a prophylactic measure. Cure, removing all cancer cells. Palliative, we can't control the cancer anymore. So maybe it's in stage 5 where it has already been metastasized. So we're just doing the surgery to live more comfortably. Example, feeding tube, central line, fixation of bones due to pathofractures. All right, what is chemotherapy? So we talk about this a lot, but what does it really mean, chemotherapy? So chemotherapy is an agent that it kills or inhibit the reproduction of neoplastic cells and also kills normal cells. So it kills bad cell and also good cells. It kills all of the cells. Symptoms of chemotherapy include fatigue, alopecia, meaning loss of hair, nausea, vomiting, which is a really big thing in chemotherapies. So we really need to take care of the patient when prophylactically because they are at really high risk for nausea and vomiting. Mucositis, skin changes, myelosuppression, including neutropenia, anemia, and thrombocytopenia. So the triad, the pancytopenia thing, they will be high risk for bleeding, infection, and also anemic. So what is nadir? Nadir is one of the most toxic form of chemotherapy, where it can cause a lot of issues with infiltrating of the line when they're infusing the chemotherapy. So we will discuss it deeper in later slide. What are the most reliable site of infection? So before reading anything, when we read the most reliable style of infection, usually that is fever. So chemo is only effective if a cell is actively dividing. Okay, so that's important to know, if the cell is actively dividing. This is one of the reasons why it is so important to catch cancer early, because it is still rapidly dividing. As cancer progresses and tumors get bigger, the cells go into a resting state and chemo is not as effective. Chemo can decrease immune system and increase risk for bleeding. Remember, neutropenia and thrombocytopenia. So we have to do neutropenic precaution. So what is neutropenic precaution? Again, no plants in the room, no fresh flowers or fresh vegetable. So avoid exposure to those recently vaccinated with live virus. And what are live virus? For example, MMR, rubella. Avoid pet excretion, including fish tanks, aquariums, positive pressure holding facility, drink sterile water, keep hydrated, anti-emetic for nausea and vomiting. These platelets, their platelets are low and vomiting can cause cerebral hemorrhage. So that's also important because these patients who having chemotherapy, they are at severely high risk for nausea and vomiting. So we have to prophylactically give them anti-emetic before they even feel nauseated. And if they are throwing up with the condition of thrombocytopenia, they are at risk for high risk for bleeding. And when they throw up, they can cause a break or a burst of a vessel in the brain, which can lead to cerebral hemorrhage and can be lethal. So please study this very, very carefully. Like, yeah, it will be on exam. Okay, so what is nadir? Nadir occurs 7 to 10 days post chemo, lasts a week or two. ANC less than 500 is at severe risk for infection. ANC is absolute neutrophil count. White blood cell less than 5,000, the patient will require neutropenic precaution. Fever is the most reliable signs of infection in patient. Patient with ANC must be at least 500 to receive their chemotherapy. Whole if neutropenia count is less than 1,800. Side effects of chemotherapy include neutropenia, thrombocytopenia, nausea and vomiting, stomatitis, mouth sores, called changes in oral mucosa, alopecia, and mucositis. Neutropenia, again, neutropenia is low white blood count, less than 5,000 or less than 4,000. Risk for infection, neutropenic precaution, reverse precaution. What do visitors wear? Wear gown, a mask. Complication, myelosuppression, bone marrow suppressions. So red blood cells treat with, if they are low in red blood cells, we treat them with transfusion or erythropoietin factors, stimulating factors, fluids, iron, epogen injection. So remember this medication from MedSurg I, epoetin alpha, also known as Progrid. This medication stimulate erythropoiesis via the kidneys, and we know that erythropoiesis will stimulate the bone marrow to produce more red blood cells. So the side effects of epoetin alpha Progrid is hypotension and thrombotic events. So why does it lead to hypertension and thrombotic event? It is because the erythropoiesis hormone lead to an increased production of red blood cells only. And when there's an increased red blood cells in the blood, it make the blood more viscosity, make the blood thicker. So when the blood's thicker, there will be more pressure in order to perfusing the blood to the rest of the body. Therefore, it increases the resistance and lead to hypertension. And also because of the increase in production of red blood cells, that's why the blood gets thicker, so it may lead to more issue with clotting and clumping, therefore may result in thrombotic event. Nursing consideration, so it can increase risk of death and serious cardiovascular events exist when given with hemoglobin more than 12. So if the patient hemoglobin is more than 12, we have to hold the drugs, okay? Ensure adequate iron store in the patient, use lowest effective dose. White blood count, we want to start neutropenic precaution to decrease infection. Neutropenia, low white blood count, less than 5,000, high risk for infection. So again, neutropenic precaution, no raw meat, milk sick, live plant, fresh flowers, mask when entering and exiting the room of patient, hand washing, do not allow anyone with recent live vaccine, MMR, rubella around the patient, avoid pet excretion, including fish tanks and equipment. Positive pressure holding room is preferred, drink sterile water, hydration is key. So when the patient is having low ANC, absolute neutrophil count, we give the patient Neupogens. Neupogens will help make neutrophils. And before we give Neupogen, usually we have to check the ANC, absolute neutrophil, before giving the med. And when the ANC level is more than 1.5, which is 1,500, we hold the medication. Or white blood counts more than 10,000, we also hold the medications. Side effect of Neupogen is bone pain and fever. The reason why bone pain is because especially the sternum area and the iliac crest area, where the bone marrow stimulating and producing the white blood count. So it's normal, but fever is fever is also a normal sign. Store in fridge but warm before giving to patient. Administer sub-Q slowly to avoid pain and burning sensation. Expected bone pain and elevate ANC. Do not stop the drug due to pain. Like I said, because the sternum and the iliac crest is where the bone marrow producing the white blood count. So when we give Neupogen, the patient will maybe experience chest pain because it's right at the sternum, or they may be experience like the iliac crest pain. We do not hold the medication we continue giving the medication. So it is essential to teach the patient that this is a normal sign. You do not go to the ER if you're experiencing pain when you are being given Neupogen, because ER is one of the dirtiest place. And these patients are on Neupogen, meaning that they are at high risk for infection. So we don't want them to go to the ER. So how do we know if it's effective? We evaluate the patient ANC. If it's more than 1.5, then it's good. Or the white blood count more than 10,000, then it's good. That's when we hold the medications. All right, thrombocytopenia. Thrombocytopenia is low platelet. So when they are low platelet, they are at risk for bleeding, and low platelet is less than 100,000 count. So we want to prevent bleeding in this patient. We do not do IM injection, suppository, meaning the medication put up their anal. We do not do enemas. Razor, we switch to electric razor. We not floss for this patient because it's can cause bleeding gums, and do not use nail clipper for this patient, or not letting them do by themselves. Teach them to use soft Bristol brush. There's like a special kind of brush that they have to use. Use electric razor instead of regular razors. No straining, meaning no bearing down when they go pooping, because that can cause, because the anal area is where a lot of vessels are there. So when they strain or bearing down, it can causes bleeding, especially if they are thrombocytopenic. Reduce. So how do we? So we also need to increase this fiber intake for them and tell them to drink a lot of water so that they won't have constipation, which can lead to straining. Okay. We need to also reduce cough, nausea, and vomiting, and constipation. Gently blow the nose, and no NSAIDs. Why no NSAIDs? NSAIDs including ibuprofen, Advil, Motrin, aspirin, because NSAIDs can cause GI bleeding. And this patient, low platelet, they are at risk for bleeding already. So it can increases the issue with bleeding. Treatment, give platelets as needed, focus on reducing risk of bleeding. Nausea and vomiting. We have to prevent nausea and vomiting in this patient because they are receiving chemo, so they are really high risk for nausea and vomiting. And if they are experiencing nausea, vomiting, they can lead to cerebral bleeding because they are low platelet. So we have to give them Zofran 30 minutes prior to chemo. Can have headache, diarrhea, fever, hypotension, promote fluids, nausea and vomiting. We treat them with antiemetic. We give them a bland diet, include banana, rice, applesauce, toast, smaller frequent meals. Prevention is key. We do not give them citrus, including grapefruit, oranges. We do not give them chocolate or spicy, fatty, or highly salted or strong odor food. All right, earlier we mentioned about stomatitis and mucotitis. So stomatitis is basically means that it is an inflammation and ulceration due to rapid cell destruction of the chemotherapy. Treatment, we give liquid lidocaine, Benadryl, nystatin, or it is a oral solution. We teach patient to hold in mouth for as long as possible, then spit out. Good oral hygiene is key. We have to use a soft brush, teach the patient to brush their teeth and clean their mouth regularly. Dental work to be done prior starting therapy, meaning prior to starting chemo, they have to do dental work because it can lead to infection if they have unhygienic oral. We need to increase intake of protein to promote healing, and fluid to prevent the dehydration of the mouth. Intervention are aimed at symptom relief and preventing further tissue damage. We floss with dental tape and use soft toothbrush. Avoid commercial washes. Avoid lemon glycerin swab, alcohol products, because alcohol product, it can lead to dryness of the mouth after using. So please make sure remember that. Medication include sucralfate, carafate. Mechanism, it will adhere to the ulcer site and absorb the pepsins. So it can cause dry mouth and constipation. So nursing consideration is give on an empty stomach 1 hour before and after and at bedtime. Patient teaching include increased fluid, bulk, and exercise to lessen the constipation. Medication is the chlorhexidine mouthwash to decrease the risk of hemorrhage and protect gums from trauma. So you guys remember sucralfate? Sucralfate is like the medication where it coats the lining of the digestive system to prevent ulcer inside the digestive system, which can lead to bleeding. And these patients who are receiving chemo, they are high risk for that. So that's why we give them sucralfate. So please remember, give them on an empty stomach 1 hour before meal and at bedtime. So we encourage the patient to chew gum and eat hard candy because their mouth usually dry, and by sucking on hard candy or chewing gum, it can increases the saliva and promote the hydration inside the mouth. All right, next we have alopecia. Alopecia, like I mentioned earlier, is hair loss in chemotherapy patient. What do we teach? We teach to avoid anything that damage hair, like hair dyes, hair curls, purchase a scarf, turban, wig before the treatment. We recommend the patient to do that. And then hair loss is everywhere. Prepare them that they will probably lose hair from their eyebrows and eyelashes too. Before we moving on to vesican, would you guys like to take a break? Or you guys want to continue, move on? Okay, yes. Sorry, I know it's heavy content. So I have 4:54 right now, so we'll come back at 5 and we start this slides. Okay, thank you. Let me pause there. Okay, I'm sorry, I have to go into repeat that, guys, because it was not on the recording. So earlier I mentioned about nadir. I said nadir was something that causes issue with infiltration on the arm, which is wrong. Nadir is the lowest point of kind of everything. So when patient is in chemotherapy, they may experience a sign symptom, which is nadir, and it causes depletion of their white blood count or red blood cells or platelet, which mean that nadir, the white blood count is at the lowest point. So nadir is a sign symptom of chemotherapy. And vesican is what causes extravasation or issues with infiltration of the IV when they infusing the chemotherapy to the patient. So sign symptom of vesican, patient can experience burning and absence of blood return, resistance of flow of IV fluid, redness, swelling, and pain at site. So what do we have to do? We definitely stop the infusion immediately and apply ice. Apply ice because usually the ice, the cold, it will constrict the blood vessel and it preventing the nadir, it preventing the vesican from spreading to the surrounding tissues. So that's why we apply ice. So if the vessels are dilated, then we will just be spreading the tissues more and cause more necrosis. Vesican is very toxic. It can cause necrosis if it is spreading to the tissue, as you can see in the pictures. Vesican and chemotherapy administration consideration. Vesican is a drug such as chemo that easily irritate the veins and can cause extravasation, necrosis of the skin around the vein. Tissue necrosis when chemo gets into tissues, IV infiltration. Must establish IV line before starting chemo. Check the IV for patency, flush, and check all lines, including peripheral, central line for blood returned. Access for extravasation if occurs. We stop the infusion first of all. So if there's a question regarding priority, what do you guys do first? Stop the infusion first. Then we disconnect the IV tubing. We do not remove the needle immediately. We will attempt to connect a syringe to the needle and attempt to aspirate, withdraw the residue vesican using the small syringe to remove chemo from prevent damage. So that's really important, okay? Stop the infusion, disconnect the IV tubing, but do not remove the needle. We keep the needle there, and then we get a syringe, an empty syringe. We hooked it with the needle, and then we aspirate as much as the residue vesican as we can. Then after that, we will apply eye because it leads to vasoconstriction and prevent further tissues damage. We assess the site for any other sign and symptom, then we notify the MD, okay? So if there's a question about vesican, we do not notify MD as a priority. We do everything like this first before we notify the MD. And the priority is stop infusion. We can administer the antidote per guideline, but this is after notifying the MD. Stopping the infusion is number one. Slowing down the infusion rate is not stopping the infusion, okay? So stop, it means stop. Destroy normal cell, so radiation therapy. So radiation is destroy abnormal cells within minimal exposure to normal cells. So like chemotherapy, it kills both good and bad cell. Radiation therapy is like a laser where it's killed the exact spot that it was designated to. It is a direct beaming on the tissues. Side effects include local skin irritation at iron, alopecia, fatigue, most common, then alteration in sensation or taste. There are two kinds. It includes teletherapy, external beam, or brachytherapy, internal beams. Don't really need to know that. Emission and distribution of energy should be targeted to area that has cancer to reduce increased risk for adverse effects. Patient must remain very still, can use immobilizer device as needed, and medicate for anxiety as needed. All right, next we have stem cell transplant. We have graft versus tumor, graft versus host disease. There are different types, include autologous, allogenic, and syngeneic. So graft versus tumor is a good thing. It indicates that new stem cells are attacking the tumor. Graft versus host disease is bad. This means that stem cells see the patient as foreign, indicates stem cells are attacking the patient organs. So graft versus tumor or graft versus host disease often occur when the patient have a stem cell transplant, a bone marrow transplant. That's what that means. Autologous is patient-owned donor. So autologous meaning that the patient have issues with their bone marrow where they may have like a leukemia or they require the need of using chemotherapy to kill all of the bad tumor or bad cancer cells in their body. So the doctor would take a sample of the good bone marrow stem cell, like the healthy bone marrow stem cell, and reserve it. And then they would use chemotherapy to kill everything in the body, including the bad cell and the good cells. And after they killing, or they think that they have already eradicate all of the bad cancer cells in the body, they then use the reserve stem cell that they have taken out earlier and put it back to the patient. That is called autologous bone marrow or stem cell transplant. Allogenic is another individual is donor, meaning that the patient will receive chemotherapy where the good cell and the bad cell are both killed, and then the doctor will put the bone marrow of a matched, unrelated, or related donor to the patient, but it is not patient own bone marrow, and then syngeneic is identical twins donor. Graft versus host disease, the reason why it's bad is because, for example, the patient receiving the bone marrow stem cell from a donor, but those stem cells will attack the patient organs. So that's bad. Graft versus tumor is good is because when they receive the foreign stem cell, it works with the patient. It doesn't attack the patient organs. So that's why it's good. Or it's attacking the tumor instead of attacking the patient organs. So what are the different oncological emergency? This include SEIDH, spinal cord compression, superior vena cava syndrome, tumor lysis syndrome. So what is SIADH? So this is excessive antidiuretic hormone is released. It leads to a result in water intoxication, hyponatremia. So tumor are able to produce their own ADH and secrete it. Also can occur from chemo. ADH retains water, so that is why our patient are at risk for water intoxication, meaning excessive of something. So water intoxication meaning they are having too much or retaining too much water. The patient is hyponatremic because the excessive water, so the level of sodium decreases. This is known as hypotonic hyponatremia. Causes include free water retention, hyponatremia, hypervolemia, fluid volume excess, hypotonic hyponatremia. Most common with lung cancer. Cancer cells, tumor are able to produce ADH and secrete it. Meaning that when the patient have the cancer cell or tumor, the cancer cells secrete the excessive amount of the ADH hormone, which lead to the increase in water retention and sodium. Chemo such as vincristine and cyclophosphamide can stimulate ADH release from pituitary or tumor cells as well. So the goal for patient with SIADH is prevent fluid volume overload. We monitor them by daily weight. If they have an excessive weight gain in a short period of time, indicating that they are at risk for hypervolemic. Do vital sign, check for edema, sign symptom with weight gain without edema, increased blood pressure, excess thirst, anorexia, nausea and vomiting, personality changes, seizure, coma, muscle cramps, hypotremia, decreased LOC, and cerebral edema is a late sign. Cerebral edema is because we pour fluid into the cell, put patient on hypertonic fluid. Treatment include diuretic. We have to make sure that we restrict the fluid in this patient. We need to fix the sodium and water imbalances by giving them oral salt tablets. We give them hypertonic solutions. Demicloxacline, this is antibiotic, but an off-label use for SIADH because it is thought to block the effect of antidiuretic hormone. All right, next we have spinal cord compression. Occurs when a tumor directly enters the spinal cord or when the vertebral column collapses from tumor injury, impinging on the spinal cord. Compression of the spinal cord itself or its blood supply by the presence of neoplasm, aka tumor, in the epidural space causes ischemia to the cord, resulting in neurological deficit and paralysis. It is severe, intense, localized back pain early, gait, wailing changes, numbness, and tingling in the extremities, muscle weakness, urinary hesitancy, incontinence of bowel or bladder. Treatment include IV steroids, radiation stat, pain management, surgical intervention, PRN. All right, next we have superior vena cava syndrome. So it occurs when the superior vena cava is compressed or obstructed by a tumor growth. Usually occurs in lung cancer or lymphoma. Obstruction of superior vena cava tumor or thrombosis in mediastinum area lung cancer patient. Early signs include facial and periorbital edema. This is because the blood is obstructed from going down to the heart or obstructed from the vena cava. So it causes pooling of the blood and lead to facial swellingness and the area around the eye swellingness. Vein distension of the head, neck, and face, headache, seizure, bulging eye, Stokes signs, which is tightness of the shirt, blouse collar, like they will have like big neck and stuff. Epistasis, dyspnea, big fix is emergency radiation treatment. We need to give them steroid, osmotic diuretic, treat sign symptom as needed, and decrease inflammation. All right, 5 more slices only, guys. Okay, we got this. So tumor lysis syndrome, I want you guys to specifically focus on this, okay? Let's take a breath and let's get this, because tumor lysis syndrome is an important syndrome in the oncology chapter, and it will be on the exam. Okay, so tumor lysis syndrome is due to the rapid release of cellular components during treatment, massive self-destruction, and 4 hallmark signs include hyperuricemia, hyperphosphatemia, hypercalcemia, and hyperkalemia. Okay, let's think with me. So every cells, guys, right? It has contain electrolyte in it, including phosphate and like it has stuff in it, potassium, like in the cells. And even a cancer cells or a tumor cells, they are consist of many cells like that. And when we do radiation or chemotherapy by killing them cells, if we do it too rapidly, these cells will burst and release all of the contents inside the cells, which include uracemic acid, phosphate, and potassium. So when it releases too much of those electrolytes or substances in our body, it will lead to tumor lysis syndrome and can lead to hypotension, acute kidney injury, issues like that. So that's why it leads to hyperuricemia, hyperphosphatemia. The reason why it leads to hypocalcemia is because calcium has an inverse relationship with phosphate. If we have a high in phosphate, we'll have a low in calcium. That's why it leads to hypocalcemia. And of course, hyperkalemia is because the cells contain potassium. So when it is bursting and there's too many cells, it will lead to hyperkalemia. Okay, so these are the 4 hallmark signs of TLS. Please remember this. Again, TLS is due to rapid release of cellular components during treatment. Massive self-destruction lead to increase release of phosphorus, decreased calcium, concentration of uric acid, and lead to acute renal failure. Risk factor, big and bulky tumors, high tumor burden, example lymphoma. Elevated LDH equal big tumor. First chemo treatment has higher risk, 24 to 48 hours. Renal failure. Again, hallmark is hyperuricemia, phosphatemia, and kalemia, and hypocalcemia. Weakness, muscle cramp, diarrhea, nausea, vomiting. Goal, we prevent AKI and cardiac arrest, because hyperkalemia can lead to cardiac dysrhythmia, which can lead to cardiac arrest. So we need to collect the electrolyte imbalance. We need to give them hydration, a lot of water, make sure they are hydrated. We need to start for them to pee out all of the electrolyte ASAP. Monitor BUN, creatinine, administer diuretic, allopurinol. Allopurinol is the medication where it help the body to excrete the uric acid. They are high risk for kidney failure due to increase in uric acid. Monitor the patient for creatinine level of kidney function, remember, and manage hyperkalemia by using insulin and D5W. Okay. Is any question about the TLS or everything so far, guys? Okay, perfect. All right, hospice and palliative care. So it's not very different, but it's different. So patient in hospice, usually they have a prognosis of 6 months or less to live. Whereas inpatient in palliative care, they can be in any stage of serious illnesses. Type of care include care is provided when curative treatment such as chemotherapy has been stopped in hospice. Care is provided in 60 to 90-day periods with an opportunity to continue if eligibility criteria are met. Care team ongoing care providing by healthcare provider, advised practitioner, yeah, stuff like that. So basically, purpose of hospice is provide care in the last 6 months of life that the patient is going to die. So everything is focused on is having promoting the comfortness of the patient. We do not cure any other more disease for this patient. We just promote the comfortness of this patient, prevent all of the symptom, make sure that they are not nausea and vomiting, make sure that they are free of pain, and it's just maintaining their dignity and comfort. Purpose of palliative care is reduce severity of the disease symptom. It's also not a curative measure. The nursing goal is to relieve the patient's suffering and improve the patient quality of life. Other nursing goals include treating dying as normal process by affirming life and neither. We're providing relief symptom, including pain and respiratory difficulty, teach the patient to cope with the condition. Benefit of palliative care is help provide a good death that is free from distress and suffering, manage persistent pain, ensuring wishes are followed. These are really not important stuff. I mean, we don't really have to know. It's kind of easy to figure out. So yeah. So I'll move on. So care for a dying patient. We don't need to know stages of grief. But let's talk about the nursing interventions. Withdrawal is patient may seem isolated or unable to respond. Nurse should converse with patient as though they were alert using a soft voice and gentle touch. Keep in mind that hearing is the last sentence. Hearing is the last sense to disappear. Restlessness, patient become restless and agitated performing tasks repeatedly. Nurse should encourage family to talk with patient and reassure the dying person. If the patient experience hallucination, talks to people who are not there or who have already died or see the object that are not there, the nurse should affirm the patient experience to both the patient and family as part of the transition from life to death. And saying goodbye, patient need privacy to say goodbye. Nurse should support the patient family and in saying goodbye, acknowledging their sadness and helping resolve feelings and encouraging the patient. Yeah, the nurse acknowledge fear of shortness of breath and administer medication that can improve the patient respiratory effort to prevent air hunger. So these last two slices are really, like common sense that we can do on the exam. Don't really focus on these, focus on the pathology, and especially the TLS, and then all the thing that I mentioned earlier. So that's it, guys. That's all the slices that we have for today. I know the content is quite heavy, but thank you so much for staying until now, and for coming. I appreciate y'all. Last topic of the semester, guys. Well done. You're welcome. Thank you. Is there any questions that I can answer for anyone, or everything is good? Thank you, guys. If you guys don't have any more questions, please scan the QR code if y'all have not done so. And thank you very much. Feel free to leave. Thank you. Stop sharing.